Good afternoon, everyone, and thank you for joining us today for our first of 2 April webinars for the SHIP Care Transitions Project. My name is Shelby Hornback, and I'm here at the Indiana Hospital Association. We want to thank you for joining us today. Tina Hillman with the Center for Patient Safety will be speaking today regarding communication, and she's actually controlling my slides. So I'll go ahead, Tina, if you want to go to the next slide for me. Thank you. So we first just want to open up with a few housekeeping materials and our project overview and objectives. Our objectives have stayed the same throughout this project, and as we continue, we just always want to be reminded of those objectives. We also want to, in regards to our webinar today, if you could mute your phone line or your audio on your computer while the webinar is going on, that would be great because we'll get some of that background music. But if you do want to speak or ask a question, please feel free to unmute your phone line and you can ask away. We also do have the chat box open at the bottom of your screen. You can see the tab. If you open that up, you can see our chat box, and Becky Hancock and I are looking at the chat box throughout if you have questions. And if you also want to type your name and organization in for attendance, we can mark that down as well. So Tina, if you want to advance to the next slide. IHA just wants to provide you with a few opportunities that are made available through this project. First is the CHEST training opportunity, which will be offered here at the Indiana Hospital Association in Indianapolis, May 21st through the 23rd. And we are excited to offer this Train the Trainer workshop. It's a 3-day event that will cover about 10 modules. So there's a lot of information involved in this, and we are happy that we will be able to provide funding for one person from each of your eligible hospitals to attend this training. It is a first-come, first-served basis, and we do have people signing up, but we wanted to open this opportunity up to you and your hospital. So if you email me, my email is at the bottom of this screen, by May 6th or as soon as possible, we'll make sure to get you and your hospital registered for this event. And then our next opportunity, Tina, if you want to advance to the next slide, is the sepsis simulation. So a part of the SHIP project, there actually are 6 individual projects, with Care Transitions being one. The other is a sepsis project, and I know a few of our Care Transitions hospitals are also involved in the sepsis project. But we have been hosting simulations across the state since February. These simulations are open to our SHIP hospitals, and we are excited to go ahead and open the last 2 simulations up to your hospital and also your partnering long-term care facility. So the first simulation will be offered on April 30th at St. Vincent-Salem, and the second, May 2nd, at the Rick Simulation Center in Terre Haute. These are half-day sessions, so they are identical, so your team members only need to attend one session. But this is a wonderful opportunity, and we are also able to provide a stipend for this as well. So if you have any interest in this, these events are quickly approaching, so if you could email, again, myself, my email at the bottom of the screen, as soon as possible, we will get you registered for those events. You can pick either the 30th or the 2nd, whichever works with your hospital. If you ever have any questions regarding these, please feel free to email me or anyone here at the Indiana Hospital Association, and we can provide you further information. So with all of that, I'm going to go ahead and turn it over to Tina with the Center for Patient Safety, and she can talk about the topic of our webinar today.
Thank you, Shelby. Those sound like really great opportunities. I'd really encourage all of you to take advantage of them. So today we're going to really focus in on communication, and I did already, for those of you who attended the patient safety forums, we touched a little bit on this in those in-person sessions. And so really what I want to do is take some time today to really expand upon communication, especially as it pertains to patients going through the continuum of care as they are being handed up or being transitioned into different areas. And just some items of note as we go through this presentation. When I say team, I am not meaning like a specific team in regards to either a hospital team or EMS team or long-term care. I am meaning team in regards to a representative from each of those areas working together. And I'm also including the patient in with the team also, because it's very important as we are communicating and as patients are transitioning through the different areas of healthcare, that we include them or include their families or any caregiver who is engaged in helping to take care of that patient. And so with that said, the objectives for today is to describe how communication affects team processes and outcomes. We're going to define effective communication. We're going to identify communication challenges, and then we're going to identify some tools and strategies that can improve a team's communication. So the single biggest problem truly in communication is the illusion that it has taken place. And I think this is really true in healthcare because we have a tendency to get so into our own little area that we know what, if we're working, say, in a hospital or if we're working in a home care agency, we know when handing off to another person within our own little area what information is required. But as we are handing off patients to different areas of healthcare, we tend to come at it from our own background. And so we don't sometimes take the time to think about what that person needs. And so that really then does lead to that illusion that we are communicating. So what I'm using a lot today is a lot of the team steps principles, and communication in team steps is the mode by which the majority of their strategies and tools are executed. And so effective communication skills are vital for patient safety as the patient moves along the whole continuum of care. And then effective communication also enables all team members to relay information effectively and accurately. And as we know through research, through researching handoffs from EMS to EDs, we know that there are several different variables that affect the successful handoff. And those can be the personnel's expectations, any prior experience, the workload, the working relationship. But they've also discovered that a lack of active listening and access to written information, which are both components of communication, are identified as major issues. And with that, I'd kind of like to touch on the point that many of us, especially as parents or as we were going through school ourselves, we know that we understand things, or many of us are learned through a certain way, whether it's verbal or visual learners. But what research has shown is that even when it comes to learning or comprehension, none of us are truly 100% just visual or just verbal. We're all a combination of both. And so that's where verbal communication backed up with some of that written communication and details is really helpful for our patients as they move through the healthcare continuum. So the lack of a strong communication has been shown to really play a part in fentanyl events. If you look back through Joint Commission and fentanyl events between 95 and 2005, ineffective communication was identified as the major root cause for nearly 2/3 of all reported fentanyl events. From 2010 to 2013, and actually even in the more recent data, ineffective communication has remained among the top 3 root causes of fentanyl events reported. So that just highlights the importance of effective communication and provides a rationale for why we really need to work on how we communicate with one another. So communication is defined as the transfer or exchange of information from a sender to a receiver. More specifically, communication is a process whereby information is clearly and accurately conveyed to another person using a method that is known and recognized by all involved. It includes the ability to ask questions, to seek clarification and acknowledge that the message was received and understood. One important result of effective communication is that there is then a shared understanding between the sender and the receiver of the information conveyed. And there's a couple of considerations you really need to keep in mind when you're communicating. The first is, with whom are you communicating? And the second is how you are communicating. With whom you are communicating, or the audience, influences how the information is exchanged. For example, if you are an EMS crew and you are taking a patient from an acute care setting, from the hospital back to a long-term care facility, how you communicate with the person you're handing off that facility will differ from how you're handing off a patient who is decompensating to a nurse in the ER. So keep in mind those differences and keep in mind with whom your audience is. And then the second consideration you need to remember is how you communicate. There are actually two different modes of communication, verbal and nonverbal. So in a couple of slides, we're going to cover some standards of effective communication, which really relate primarily to verbal communication, but I really want to take a few moments right now and just discuss nonverbal communication. And nonverbal can take several forms. There's written communication, which is common in healthcare, but has really kind of migrated over to what I call more data entry. But we write orders, we write down vital signs, or we enter them into the electronic health form. So that is one form of communication we have. And this type of communication should still adhere to many of the same standards we use in verbal communication. In addition, in both written and verbal, we need to be mindful of the abbreviations we use. In those patient safety forums, I used a couple of examples of acronyms that in healthcare, we mean it to be one thing. For example, CPR was the example I used. We've come to recognize that as cardiopulmonary resuscitation. But in other areas of, say, in-home care and other home-based care environments, a CPR is a tool that is used for a community partnership referral. So they can mean a couple of different things. So make certain that any acronyms or abbreviations you're using are standardized and the meaning is well understood by everyone involved in the communication. Another form of nonverbal communication is body language. The way you make eye contact, the way you hold your body during a conversation are signals that can be picked up by the person with whom you are communicating. Body language actually plays a huge role in any type of communication. When you are verbally talking to one another face to face, the words that you use only account for 7% of the meaning. Your tone of voice accounts for 38%, and your body language accounts for the remaining 55%. So this is a very powerful form of communication, but this mode of communication is not a way where you as a receiver can either verify or validate the information that you are receiving. So then going on to other forms of nonverbal communication is visual cues. And that's another one that we use a lot of in healthcare. For example, using color coding for assignments, for charts, for ID bands. Many organizations will use a red colored band for allergies, maybe a yellow band for a fall risk, and maybe a blue band for a do not resuscitate. So we use these visual cues for communication also. So we really need to make certain that to avoid making assumptions that could lead to error, we should always verify either in writing or verbally any nonverbal communication to ensure patient safety. The simple rule to keep in mind as you are communicating is that if you are in any doubt or have any questions, you need to check it out and you need to come out with those questions and ask them. So as we communicate with one another, there are some standards that we need to follow. And these standards pertain to anyone in the team and to our patients or our patients' family members. Effective communication should always be complete. We should communicate all relevant information while avoiding any unnecessary details that may lead to confusion. We also need to make certain that we are leaving time for questions, and if that there are questions asked, that we answer them completely. We need to be clear, so we need to use information or language that is plainly understood, and we need to use common and standardized terminology when communicating with members of our team. We need to be brief, and we need to be concise, and we need to be timely. We need to be dependable about offering and requesting information. We need to avoid any delays in relaying information that could compromise our patients. We need to note times and observations and interventions in our patient's record. And these are things we should be saying verbally as we're handing off reports, but maybe also including a sheet maybe at the top that summarizes observations and interventions in a patient's care. We need to ensure that we are updating our patients and their families frequently and not keeping them in the dark when any changes occur. We need to verify authenticity, and this requires checking that the information received was the intended message of the sender. And then we also need to in turn validate or acknowledge the information, letting people know that we received it. Just hearing it and knowing that we heard it and then walking away leaves the person who's giving us the information wondering if you really heard or you understand what they were saying. So these are just a few brief examples of not being brief or not being timely or not being clear. Example of not being timely would be, let's say you did pick a patient up who is decompensating at a long-term care facility, and as you are handing them off to the ED, they decompensate even further, requiring a rapid response. In the middle of that rapid response, after some emergency medications have been given, is not the time to suddenly shout out any patient allergies. The time to do that would be immediately as they are decompensating to shout that out. So that's just an example. So many times we face challenges to communication, and this just kind of lists some of these challenges that we need to keep in mind, and sometimes that we need to take an extra step to ensure that information that we're relaying or communicating is understood. Especially with our patients. Maybe there's a language barrier. Maybe our patient doesn't speak English, and so that could mean either trying to find a healthcare provider who does speak that language, or ensuring that there are interpreters nearby. Physical proximity. I'm certain you're all aware we all have our own little like personal space, personal bubble. And for some people that's a bigger personal bubble than others. And so just being aware of the fact that some people do have that large space, because if you are trying to communicate with someone who does have a larger personal bubble than what you do, and you keep getting closer, their mind is not going to be on listening to what you're saying. They're going to be focused on backing up and trying to keep you at a safe distance. Personalities can play a part in communication. Sometimes it can be difficult to communicate with certain individuals, especially if you are someone maybe who is an extrovert, a very big extrovert, and you are communicating with someone who is an extreme introvert. That can lead to some difficulties. Workload plays a role in our communication, varying communication styles. Historically, depending upon the area of healthcare that we are working, we've been trained to communicate in different ways. If there is conflict between the two individuals communicating, that can disrupt the flow of information between the two individuals. If there's unclear expectations, that can lead to information not being shared because maybe you don't know exactly what the person is wanting or how much information to give. If there's a time expectation or a time compression, let's say for some reason the handoff is occurring during shift change, that can be rather difficult because shift change has been researched and it is documented that that is a time when many communication breakdowns occur. And then lastly, distractions and competing technology. This can really lead to either information not being absorbed appropriately or not being heard, especially if there are many alarms going off, if phones are going off, beepers, pagers, etc. That can all lead to challenges with our communication. So knowing that these could be challenges and trying to find ways to go around these challenges or handle them so that they don't affect our communication is very important. So there's a number of tools and strategies that we can use to potentially reduce errors associated with communication. The following 4 strategies are simple to integrate into your daily practice and have been shown to really improve team performance. You've got the SBAR, which is situation, background, assessment, and recommendation, and then call out and check back and handoffs. The handoffs in particular can take many forms, and we handed out a couple of examples when we were visiting your organizations for the forum. In this presentation, I'm also going to cover the I Pass the Baton handoff tool, and that is one that's a little bit longer. It's been developed by physicians to use, and it's just another one that you can use. And then lastly, there is going to be a slide with several other different tools. So going on to the SBAR, this provides a standardized framework for the healthcare team to communicate about a patient's condition. This could also be referred to as the ISBAR, and that would be where the I stands for introduction, and that's especially important as we seem to be entering a period right now where we have a lot of turnover in healthcare. And so starting off with that introduction of who you are and what your role is in the patient's care is really helpful if you're communicating with another healthcare provider. And then going into the situation as to what is going on with the patient, the background of what is the context of the patient, what's the clinical background. And this doesn't mean the whole historical background. You could have a patient who has COPD and CHF and diabetes, but if the situation that you're discussing with your healthcare team member specifically pertains to maybe the COPD, that's the background you want to give. The patient has had COPD times however many years and has a history of smoking cigarettes times however many years, and go into the details then of that particular exacerbation or what's happening and how it pertains to the situation. Then you want to go into the assessment, what you think the problem is, and then if you've done a recommendation, sharing it with whoever the team member is that you're talking with, whether it's a doctor, whether it's a paramedic, whether it's another nurse or an aide. Giving a suggestion so that you can start that conversation as to how to treat your patient. And the SBAR is a really good framework because it's broad enough that it can be used as a communication tool between team members in the same environment, between team members in a hospital, team members in an EMS crew, or team members even in a long-term care facility. And it's broad enough also that it can be used as a handoff tool also. So a call out is one of those that's used for a specific situation. It's a tactic to communicate critical information during an emergent event. Critical information is called out in these situations to help teams anticipate and prepare for vital next steps in the patient care, such as a rapid response or a code. And I know this sounds like it would be one that's used specifically within certain environments, but I think it's a good one to know for handoffs, because handing off patients doesn't mean that they're always stable when you hand them off. There are many times when, as we're handing off a patient, whether it's from a long-term care to EMS or from EMS to an emergency department, where a patient can suddenly decompensate and everyone is involved in the rapid response or the code of that patient. And so utilizing a call out really helps each team member know what is going on, what to anticipate, and whoever the recorder is helps them to keep track of what is going on to write down to put into the patient's charts. So a check back is a strategy to close the loop in the communication. So it allows people to verify and validate the information exchange. And this involves, in basic terms, a sender sending a message or a communication, the receiver accepting that message and confirming that it was received, and then the sender once again closing up the loop. So going back to this example of, say, a patient who was starting to deteriorate, and let's say long-term care has called in the EMS crew. So the long-term care nurse tells the paramedic, this patient has a normal blood pressure of 110/70, and this morning it was 90/60, and right before we called you, it had fallen to 80/48. The EMS crew member then says, got it, the BP has been falling and most currently was 80/48, down from 90/60, down from a normal of 110/70. And then the long-term care nurse would complete the loop or close it by saying correct. So this is just a tool. It sounds like some extra steps, but it's just closing that communication loop and ensuring that there's no gaps, that the person receiving it received it correctly, and the person sending it is confirming, yes, you received it correctly. This tool is also, one of the things I like about this tool is it is the foundation for the TeachBack tool, which then can be used for as we work with our patients. And so as we think about, you know, in the last presentation, I talked about COPD and utilizing community paramedicine and integrated mobile integrated healthcare. The TeachBack is based off of this. And so we can be using this type of framework to be teaching our patients how to recognize symptoms, their medication, checking to see if they understand their medication, all with the goal of ensuring that they are staying in their homes and that they're not having readmission. So this is a really valuable tool to just start integrating into daily practice. So the next tool or strategy is the handoff. And, you know, I'm certain you see this picture that I talked about before, and that the baton is really our patient. And so a proper handoff includes the following, which is the transfer of responsibility and accountability. When you're transferring that information needs to be clear and concise. You need to have verbal communication. There for a while, it seemed as we were using electronic health records, we were trying to hand off patients to different areas of healthcare with just sending them the discharge paperwork or sending them forms from the electronic health care record. I know this has been a form of discharge or communication with home health for many years, was just to send over the discharge paperwork. But truly, you really need to do verbal communication of the information and use the written as like a backup. The verbal communication allows time for questions, and it allows that opportunity to review. So a handoff truly consists of the transfer, like I said, of responsibility, and then the last thing in the verbal communication, and then also that opportunity to review. So here is the I Pass the Baton tool that I was talking about. And this is one that is very in-depth, so it's not like a short tool to use, but it's a good one to use because it gives you the concept and the framework and allows you to really think about the information you want to share. So with the I Pass the Baton, you want to start off with introducing yourself and your role and how it pertains to the patient. For the patient, you want to include their name, their age, their sex, and where they're coming from. For the assessment, you want to present the chief complaint. This is not a time where you want to go into a whole historical background. You just want to present the chief complaint, what the current vital signs are, symptoms that they have been presenting, and maybe a pertinent diagnosis pertaining to the symptoms. You want to give any current status, including a code status, including family support, any type of recent changes, any med changes. The second S for safety. This is where you want to include any type of critical lab values, any allergies, if they have any alerts. Background, this is where you might want to go into a little bit more of their background, some comorbidities. You don't need to give their whole historical background, but let's say the assessment in the situation does pertain to COPD. Well, as a background, if they have also a diagnosis of CHF, you really want to include that as part of their comorbid diagnoses. And then any previous episodes of COPD exacerbations or pneumonias and what their current medications are. And if there is any pertinent family history, you don't need to go into family history of cancer if the current situation has to deal with COPD. And then actions, you want to include any type of interventions you have done and provide a brief rationale. And then timing is very important. If you have administered any type of medication, whether it's pain medication, nebulizer, you really need to let the person you're handing off to know the times that you administered that to keep from overdosing our patients. We need to share who is responsible for the patient, who the primary care physician is, and include any patient and family responsibilities. If you know that there is a daughter or a family member who comes and daily to ensure that this patient takes their medication or that comes over weekly to set up their medication in a planner, include that person in your handoff. And then what are the next steps that are being planned? So that you've got that outline of what's going on with the patient, what some of the decisions that have been made, and you've got a timeline to hand off to the person whom you're talking to. So these are some of the examples that we handed out at the forums. We handed out the MIST, which is you start off with the mechanism or the medical complaint, and then the inspection or assessment. Then you go into vital signs and treatment, and then also the I-PASS, in which you start off with the illness severity. Are they stable? Do they bear watching? Are they unstable? A summary, you want to summarize events leading up to the admission or the decompensation of the patient, their hospital course if you're handing them over to a long-term care, the ongoing assessment, and what the plan is. Then you want to go into an action list, and this is the to-do list. You know, if they're going back to long-term care, they're doing smoking cessation classes, they're doing pulmonary rehab, they're being followed up, they've got a follow-up appointment in 2 weeks with Dr. So-and-so. situation awareness, and then any type of contingency plan should something not go right. And then the synthesis by the receiver, and this is where the person receiving the handoff or receiving the patient has an opportunity to ask questions and restate those key actions in the to-do list. Some other handoff tools include Anticipate, which that goes over administrative data, any type of clinical information, tasks to be performed, the illness severity, and then contingency plans for any changes. The SHARP tool is very similar to the SBAR tool, and then it goes into the situation, pertinent history, assessment, recommendation, and allows for questions. The HANDIT tool is a handoff intervention tool, and I included the website where this can be found at. And this was a whole research article that developed then this handoff intervention tool. Then there's the patient handoff toolkit, and this was put together by the AORN. And in this toolkit is 10 different examples of handoff tools. And then there's also the Safer Sign Out form. And this was developed to standardize the sign out process. And again, I've included a website to go to for that form. The important thing for this project that I'd really like to emphasize is to really meet with all of your community partners, hospital, long-term care, and EMS, and really decide on a tool for all of you to use and to try and use the same tool. Because if you're standardizing the tool and you're all using the same tool, then you're following the same process and there will be a chance for questions, and it provides that template for ensuring that all pertinent information is shared with one another and that there's less of an opportunity for information to be dropped. So let's go into kind of a summary of what we've discussed, and then there can be, and then I want to go over some few remaining webinars for this project, and then we can go into some questions. So in summary, as we discuss communication, we need to recognize that there are always barriers and identify those barriers and try to find ways to overcome them. And as we do that, we need to be aware that some of those barriers include things like inconsistency in team membership. Sometimes we've got a lack of time, especially if the handoff of the patient is happening during shift change at the facility where we're at. There could be a lack of information sharing. Maybe we forget to hand something, forget an important piece of information. The whole hierarchy of medicine sometimes can play into barriers with communication. Sometimes if we are receiving information from a surgeon or from a doctor, there might be that fear of asking questions, but we really need to understand and realize that that type of culture doesn't play into helping our patients, that if they state something and we don't understand it, we should be stepping forward and asking questions. If there is defensiveness among either team member, that type of body language can be sensed by the receiver. And so then there can be a hesitation to ask questions. Conventional thinking can sometimes lead to important information not being shared that might lead to a correct diagnosis versus the wrong diagnosis. Sometimes we tend to get complacent as we're transferring our patients from one area to another, especially if it's a patient we know well. We tend to be a little complacent and just use that conventional thinking of what historically has been wrong with the patient, instead of with each and every situation trying to make certain that we're headed down the right path. Varying communication styles can be challenges if there's conflict between the two people communicating. If there's a lack of coordination and follow-up with coworkers, this can lead to communication during transitions falling apart. And this is where I'd say it's really important for those of you who have started these meetings with your EMS crew and with your long-term care facilities in your area. to continue with those monthly meetings, because that helps to improve the coordination and follow-up to ensure that your transitions and your handoffs are going smoothly, and to identify any that didn't go smoothly and what the root cause might have been, and find ways to overcome those transitions or handoffs that didn't go smoothly. Distractions are always a barrier. Fatigue, if you're working the end of working a 24-hour shift, or if you're doing overtime, that can always play a role into communication failures. Workload plays a role in communication failures, misinterpretation of visual cues, and then lack of role clarity. Some of the tools and strategies that we've covered that help with our communication include the SBAR, the call out, the text back, and the handoff. And I'm just going to reiterate, finding that handoff tool that works well for you and for the members in your community is so important. And so the outcomes of using tools and strategies and standardizing our communication comes out to a shared mental model to ensure that our patient is transitioning through the healthcare continuum with a decreased risk to their safety. It allows us to adapt to different situations. It has an improved team orientation. We know the tool, we understand how to go through it. We know we need to close that communication loop and verify that we're hearing things appropriately and we're understanding them appropriately, which then leads to mutual trust in regards to our team members in the community, which leads to improved team performance, which, putting all this together, improves the patient safety. So before I close out, I'd like to remind you that we still have a couple more webinars coming up. The next one coming up will be another clinical one on high-risk transitions, and that's coming up on April 24th. Then our final webinar will be a sustainability webinar, and this will be some tools to put into place to try and keep any changes, any process changes that you started to implement, to help keep them going. And then lastly, as we are starting to wrap up the project, I'd really like to try and reach out to all of you and kind of see if you are needing anything from us, if there's any tools we can provide, any suggestions we can give to help you keep with the improvement in your transitions of care, to help keep the improvement going, any type of tools that you might need. So I'll probably be reaching out, either myself or a member from the CPS team will be reaching out to you. And so with that, if you have any questions, feel free to ask them.
Yes, thank you so much, Tina. And if you have any questions, feel free just to unmute your line and you can ask away. Also, please feel free to use our chat box. We'll be monitoring that as well. So if we have any questions, go ahead. I would like to remind you that we do have the 2 training opportunities that were mentioned at the beginning of this webinar, and I will be sending out a PDF of the slides and the recording, so you will be able to refer back to those simulations. So if you also have any questions regarding those training opportunities, you can ask now or you can email us later as well. All right, so Tina, is there anything else you would like to say before we go ahead and adjourn for the day?
Not really. I would just like to, well, I guess I'd just like to say that communication, whereas teamwork is like the heart of everything that we do for patients, communication is the core of everything that we do. It's the core for that transitioning along the care continuum, and that's really all I'd like to add.
Great. Well, thank you so much. And if we don't have any questions, we'll go ahead and give you back about 15 minutes of your day. Like we said, just go ahead and contact me about the training opportunities. And then I will also be sending out the webinar and the information that was presented by Tina today regarding communication. So with that, we'll go ahead and end for the day. Thank you so much for joining us.
Thank you.